Welcome to Physio Global. To our regular listeners, yes, we're doing things a bit differently this time. We switched to English for a series of short, bite-sized episodes recorded live at the Pain Science in Motion Congress in Brussels. In this special format, we're diving into the latest insights straight from the venue as we chat with different researchers behind their inspiring poster and oral presentations, giving you quick, valuable insights. This episode is brought to you in collaboration with Pain in Motion. Happy listening.
Roland, welcome to the show. We just were witnesses to your wonderful poster presentation about an interesting subject. Maybe you can start off by introducing yourself and then take us through what the main subject of your presentation was.
Okay, well, thanks for the invite. My name is Roland Reezigt. I'm a physio and manual therapist, and I do research in the line of manual therapy and how the working mechanisms could be. And that was what this poster was about. It was the last one in my PhD journey, and here we try to look into if there is an effect of manual therapeutic techniques on central pain processing. It was the poster showed a few results. We're not done with the study yet, but we found some interesting things already.
So you researched what a manual intervention or technique from a therapist could mean for central sensitization?
No, specifically for central pain mechanisms that could be changed due to central sensitization as well.
That is one of them.
Yeah, so the intervention that we looked at, so manual therapeutic techniques, is mobilizations, so where they gently move the neck in a lying position. So the manual therapist did that for like 5 minutes. And the other technique that was directly done after that was a high velocity thrust technique in a seated position for the manual therapist, known as the Nelson maneuver, a really safe and often used one. So that was the intervention. And the rest of the setup was we do measurements first to identify how those central pain processing, how it functions in those patients. And then we want to know, after that very short intervention, does it change? So do we have any effect on that? The reasoning behind that is we know that, well, in the daily clinical practice, what we see is that many people benefit from manual therapy. But we need to know why and who benefits best. What we also know, typically, it doesn't really matter if you do the techniques in the correct area, as in whatever correct is, but if you would do manual therapy on the upper back for neck pain, it seems to be very effective, even as effective as neck techniques for the neck. So you could then think that there is some central aspect to it instead of a local aspect. That central aspect is the thing that we want to, well, let's call it disentangle. What's going on there? And does it work equally in everyone? And what? That's the mission.
Because that raises a lot of questions on the mechanisms behind it.
Yeah.
What can you tell us about this?
Well, first of all, we need to acknowledge that looking into these mechanisms is not easy because humans are extremely complex. So everything we do is kind of a approximation of something that we know that works that way in animals. We can't know for a fact that it works equal in humans, but we have that kind of paradigm of measuring. So the main thing that we use is experimental induced pain. So we, in this study, use pressure pain threshold. So you push into an area with a device, and then you check how much force you give up until the patient feels that it becomes painful. So that's the pain threshold. So that says something about pain sensitivity. So that's the basic measurement we use. And then if you do that under a different circumstance, so under a conditioned situation, then we can evoke a specific mechanism that we have in our brainstem, typically called descending controls. So if I do that PPT together with a conditioning stimulus, so not psychological conditioning, but a stimulus from a different condition. What we typically see then, so in our study we did the foot in ice cold water, is that they can handle more pressure before it becomes painful. So they have an inhibitory effect. We call that conditioned pain modulation. And that is the specific thing that we focused on in this study. Does that size of that CPM effect change due to our manual therapeutic technique? That's what we kind of hope to see. And interestingly, we saw it.
Yeah, that's always good to hear if there's some positive outcome or something which is changing a lot for the profession. There's a lot of pain science going on in the world globally. What makes this one differently from other research?
It's not that different, I would say, but I think the drive is good. So it is clinically driven. We see that manual therapy, those techniques help some people. So we need to understand
that panel was common within the profession.
Yeah.
And you will want to find out.
Yeah, and the study is set up in such a way that it is in the clinic as you would do it in the clinic. It's done by manual therapists. So it's real. That also has some disadvantages logically for scientific rigor, but we want to keep it real. So that makes it good. And what I think makes it innovative, we do not have studies on conditioned pain modulation, and the other factor where we looked at was temporal summation of pain. We don't have that seen yet done by other groups, only in, as far as I am aware at this moment, very specifically osteoarthritis. There they tried it, and there is a group that did it in the neck as well, but didn't find that much. But the intervention was also not equal to ours. So that makes it a study that's worthwhile. But the disclaimer directly is the study can't prove anything. That sounds weird, but it's. I think you should see it as, if we can't find anything, we should let it go. If we do find something, and it seems that we found something, then we need to study what we found in a study set up for that. So we need to disentangle what we found. Where does it come from? Is it actually a manual therapist?
It creates then more questions to find out.
Yeah, this is really a first step in a journey. Yeah. Even though it's the last step of my PhD, it should be the first step in loads of follow-ups.
And you talked before with the Nelson high velocity thrust technique. That one is familiar for manual therapists in the world.
Yeah.
Was that the only intervention you were using as well? Or
there were 5 minutes mobilizations.
Right.
And
of the thoracic spine or of the neck?
Of the cervical spine, so of the neck in a lying position, so relaxed lying.
It's all like protocol, the same line of setting up doing techniques.
But the protocol is a bit open as in the real life situation.
Okay.
So the therapist...
what do you mean with open?
Yeah, the therapist can choose at that moment which direction of mobilizations are probably the best according to his expert guess.
Okay.
So we did not say do it for 2 minutes to the left, 2 to the right. No, do what fits this story.
It's the time frame for that area.
Yeah, so they have 5 minutes, but they can choose their own directions.
Okay.
Yeah.
And the reason of it is because that's more clinical relevant, because any therapist is using different techniques on their own way.
So in study types, you always have to choose, do you do it fully protocoled, so it's highly standardized, up until more real life kind of situations. There are different type of designs, and it has to do with efficiency and efficacy and that kind of things. So we chose to do it real life-ish.
Yeah, that's very interesting, this one, because which protocol setup will be suits for clinical implementation of the results of your research.
And that makes it interesting and hard, but for all that are a clinician, you choose somehow which technique fits the situation, right?
Yeah, for sure.
And that can't be fully standardized.
No.
And logically for science, we want to do that, but sometimes we have to acknowledge you can't.
Do we understand why someone who has their foot submerged in cold water feels less pain?
Yes, we know. A very good question. So that is then what is termed the conditioned pain modulation effect. What it probably is, so I have to put in a bit of nuance. What it probably dominantly is an activation of cells in the brainstem, in that area, like the PAH, the RVM, that area. They can be activated and they have an inhibitory activity. In humans, we can't measure those cells. We can't put needles in them to see if there's any activity. They did fMRI, then you do see activity there. But in rodents, in those kind of studies, you can, and there it can be very specifically measured. As such, it has a different term there, and it's called DNIC, diffuse noxious inhibitory controls. And there you really see at the moment you give a secondary stimulus, while you also do that first stimulus, that you got a complete inhibition of nociception. So that's what is the idea when we measure CPM, that we measure that thing, but we are humans. If you have your foot in ice cold water, there will be distraction as well, or enthusiasm, or perhaps your attention will slowly fade away. Many possibilities are there. So CPM is a paradigm to measure DNIC, but we have to accept it's now not perfect because we can't do it perfect in humans.
Yeah, it's the best option right now.
Yeah, it's the best we have, and I don't think we can do it better because we are humans. Yeah, so to summarize what we think it is the activation of the brainstem, the descending controls that have hopefully in most people an inhibitory effect.
With this study and anything else which is still going on in the future, what do you predict as an outcome?
Well, based upon what we see now is that we do have an effect on central pain processing mechanisms. I think, and probably everyone can agree with me on this one, it will be true in some, but not in all. So I think we can slowly but steadily better understand who are the persons where this will happen. Hopefully we can then predict on who it will happen, and as such we can do a form of more precise medicine, personalized care. So that would be the utopian dream, right? We only do those techniques in those that it will work, and we stop doing it on those that it will not work.
And then maybe the day after or the years after, there's some research going on which groups are more efficient for this kind of approach.
Yeah, perhaps we can find predictors at some moment.
Making the outcome stronger for that population.
Yeah.
And then you know before which group isn't suitable for to see as
that would
a
be awesome
therapist.
for us as therapists. If you could predict your own success.
And create a better prevention, like which population do we need to see and which aren't.
That would be so good if we can do that. So then we only have optimal care. That's the utopian view, right?
Yeah, and there's a better cost effectiveness for the healthcare as well.
Yeah,
so,
indeed.
It's a good one.
Yeah, so that's the dream. And we need loads of steps to go there. And you never know how measurable and predictable life will be. But if we can close the gap a bit, I'm really happy.
It's all about changing the utopian dream to a dream become real.
Indeed, making it real.
And you mentioned before that there's a excitement factor to putting your foot in cold water. And then with the Nelson technique, you can sometimes hear or feel something move. Is this like a popping sound in the vertebrae? Is this something that could affect the perception of someone?
Yeah, we have. There is data in the world that the popping sound is part of the ritual, so it's a contextual factor that's important. So what it is exactly, as in why it works, but for now, for this perspective, it doesn't really matter. As in, what we did in our study is we go for that popping sound, because I think most people agree that's kind of part of the deal. So we agreed that even though...
Yeah, just like an expectation from the patient before.
Yeah, something like that, yeah, or something like a confirmation that it went right. So I think, based upon studies done, that the popping sound is not necessary, but it seems to be part of the whole ritual. So we've decided to go for it. So if we don't have a popping sound in the first time, we just do it again. And yeah, I think that indeed has a strong, or at least has an effect, contextual, I guess, yeah.
If you look at your publication in the poster, which were presentation today, what's the sample size now going on with this?
At this moment, we are at 44, and
Okay.
we will finish it with 60, and that should be enough to detect a reasonable effect. So if the effect is smaller than that, we won't detect it. But that's good. If the effect is so small, then it's not worth it.
Yeah, right.
I guess. So yeah, we'll go for 60. And well, part of this conference is also to talk about the challenges of doing science. Well, the sample size or the recruitment, I have to say, that's one of the challenges.
It's a challenge as well.
Yeah, I thought it would go way faster. I naively thought that I would do this in like 3 to 6 months when I started this specific study. And I think it's 2 years later now, and here we are.
Yeah, this one is a pattern I'm hearing a lot from researchers.
Yeah.
The difficulty to create data with the sample size and motivate participants for your study to take part of it. And
the clinicians to include people.
Yeah,
clinicians
that's
and
in
the
mind,
clinicians
the
one.
thing. The patients really like it, and even the measurements, even though I provoke their pain and I do induce experimentally pain, we see that their clinical pain actually goes down by it, so that's also very interesting. So they are really willing to do it, and all are really happy. But, and in the beginning it made me a bit frustrated, it seems that many physios don't ask their patients to participate in the study. So that was annoying for me. However, I have to turn that around now. What we see is that our physios or manual therapists are so focused on the patient itself to help them that they forget that we also do studies. So they prioritize the patient itself.
Yeah,
that's good.
The day itself.
Yeah, so if you think about it, it's good. Somewhere it's also good that they forget about my study, because they really focus on the patient. But for me, I would really hope that they think a bit more about my study.
So, yeah, it should help if there's some change going on in the future, right? Getting the clinical practice more involved for creating input for researchers.
Really good point.
And back then, getting the patient itself better for
so
healthcare,
bilateral,
providing healthcare.
Yeah, bi-directional collaboration is indeed something we need. I have the luck that I'm a clinician myself. So that the thoughts are informed by the clinic, and also kind of brainstorm technically, also challenged by patients. You talk with patients about this stuff. But I think many research groups would really appreciate way better or more collaboration with clinicians. Because you need the patient, you need the clinician to do smart things, I guess.
Yeah, and the clinician needs research like this to further prove their worth and enhance their treatment.
Yeah, the better we can help our patients. That's the goal we all have as clinicians, I guess. We really want to help people.
So, for my point of view, it's some kind of call to action, right?
Yeah, I think that call to action.
Everybody needs each other.
Yeah, we need each other. We need to help each other.
Right.
Well, that's awesome. Roland, thank you for joining us for this conversation, and we wish you all the best in enrolling the last few people to your studies.
Thank you very much.
Thank you.
Thank you for listening to this episode of Physio Global. Would you like to discover more episodes? Then visit our website at physioglobal.nl. If you have a question or would like to get in touch, please send an email to info@physioglobal.nl or visit the contact page on our website. And of course, don't forget to follow us on social media. Physio Global, bringing the world of physiotherapy to you.